Yes, please.
Just for you
That
to
sounds
know.
good. So maybe we can take a couple of minutes for the people to come in. Let me say hello for a couple of people I want to know. Tom, I saw you are in. Eugene, you are in.
Yes, Oscar, I'm here. Thank you very much for having me. Silvia, great to see you. How are you this evening?
Nice to see you.
What a pleasure.
Where are you? Spain, Italy, the US?
I'm in Italy.
Italy?
Yes.
Sounds good. So we have, mostly are we okay? You let me know, Astrid.
It's up to you, Oscar. We are 33 up to now. Yes, Oscar, please, if you can tell to all the people who are here right now about changing the language if they need.
I can say that. Okay, if anyone who needs to change the language, you need to click on the interpretation globe, the lower part of the screen, and from there you pick the language you want to hear. Is that okay? Eugene, are you going to get Spanish or English?
No, I can only get.
Okay, just a joke. So
I'm testing the English channel just in case for everyone to check it.
Yes, Gabriela, we can listen to you.
People is getting in, and hope more people is coming in.
Yes, I am admitting some people.
You are meeting some people. Okay, go ahead. So I'm going to start it, and I want to thank everybody for joining us in this opportunity to have a first-class speaker, unbelievable to have her in our meetings. And I want to thank the World Society of Arrhythmias, SADC, SAC, and PAC for joining us to have this important meeting with Silvia Priori. We know that Silvia Priori is one of the #1 investigators in inherited arrhythmias. We know her for many years. She is very important for us, and she has been designed by the local SADC Society, Argentina Society of Pacing and Electrophysiology, as honorary president of the Inherited Arrhythmias Board. Behind that, we are going to start her presentation because we have a group of panel people who is going to make her questions, but we are very interested, dear Silvia, our professor from Milan, to tell us what are the new advances and future advances in the management of inherited arrhythmia. Silvia, please go ahead.
Thank you very much. Ladies and gentlemen, good evening. I'm very proud and very happy to be delivering this speech, where I would like to talk about the management of inherited arrhythmias, a little bit on what it is now, but most of all by focusing on the new advances that will move the field beyond pills. So when we think about the impact that genetics has made in the management of these conditions, we think about the early steps, you know, when after the discovery of the disease in the 60s by the Italian team of Dr. Romano, Gemme, and Pongiglione in 1963. The second report came from Dr. Ward in 1964. And then a pivotal step as an advancement to the understanding of what we call now inherited arrhythmias, and at that time were called familial sudden death or unexplained familial sudden death, was the development of the International Registry of Long QT Syndrome in the United States, coordinated by Dr. Moss, and in Europe, coordinated by Dr. Peter Schwartz, and Crampton was also part of this initial effort. It was so important to have this repository of clinical cases. The importance of this was understood when we approached the time in which the field was mature to investigate the genetic substrate of these conditions, and especially the registry was pivotal for providing samples of blood from which DNA could be extracted to Dr. Mark Keating, that has been really the leader and the person who has identified all the major genes for long QT syndrome, thus opening the field to understanding the genetic substrate, not only of long QT syndrome, as we see here in this pivotal paper from Mark Keating and Igor Splasky, that really shed new light on what we could do and what we should do in the investigation of inherited conditions. We followed the track of Mark Keating, studying a disease for which we had collected large number of patients with catecholaminergic polymorphism VT, a disease that was originally described by another giant in the field of arrhythmias, Philippe Coumel, who in France described this disease in the 70s. We were able to identify that the ryanodine receptor was the gene for the dominant form of catecholaminergic VT. Subsequently, other recessive forms have been identified, and we now know that other genes like calsequestrin, triadin, and tecryl are important genes for CPVT. But from a number of patients, the ryanodine receptor remain the leading gene that causes the majority of the forms, the dominant forms. Then a long track of other identification of arrhythmias followed, and of course, also in the field of cardiomyopathy, genes started being identified. At the beginning, the genetic was used as classically genetic is used for making diagnosis in family members. And this was just the beginning of what then became a field that matured in different directions. I'm showing here our study in 2003, when we thought about using genetic not only for diagnosis of people, but once we had diagnosed in a family the presence of a disease gene type LQT1, 2, or 3, then we thought about using the genetic substrate as a risk stratifier to predict sudden death. And this study highlighted that LQT1 is more benign than LQT2 and 3, and that beside the genetic substrate, the duration of the QT is the second very important indicator of risk in the patients. So here we see how genetics started penetrating the field and moving from diagnosis to risk stratification. And in 2010, a new frontier was opened with the introduction of the first animal studies, preclinical investigation on the development of gene therapies to make the heart beating right, to prevent the arrhythmias that are that makes these inherited arrhythmias so lethal and so dangerous for patients. And I am focusing, and I would like to talk to you about the gene therapies, because I think that we are now at the time in which the approach to the clinic is getting very close. It is expected that the first clinical trials, of course, randomized clinical trials as investigational first step in humans, will start in 1 to 2 years. So I started speaking about gene therapies in 2010 when we published our first work on gene therapy in mice, envisioning that maybe it would take another 10 years, 15 years to get to the time of the clinical testing. And the field has moved so rapidly that probably I have been a little bit pessimistic, and the reality will prove that this therapy will come much sooner than that. So when we look at the treatment of CPVT, for example, from the ESC guidelines, we still see that the majority, the first-line therapy for inherited arrhythmias, and in particularly for the two adrenergically mediated arrhythmias, CPVT and long QT, is based on the use of beta blockers. And we know that, especially in CPVT, beta blockers are useful. They reduce the amount of events, but still a quite large number of recurrences occur, partially related to the lack of compliance of patients, because carrying a therapy with pills for an entire lifetime is something very difficult. And therefore, it's clear that we need to go beyond the beta blockers. The beta blockers remains a very logical treatment because the trigger is an adrenergic one. But over time, other supports and integration to beta blockers have appeared. And for example, the ICD is one of the enhancement of the response to therapy and the protection of patients, together with left cardiac sympathetic denervation. Then the guidelines are not clear really in determining whether the failure of beta blocker should be followed by ICD or by left cardiac sympathetic denervation, leaving pretty much to the individual clinician the choice what to make the second step after the failure of beta blockers. So we have already something that goes beyond the pill, the antiadrenergic therapy, but nothing is really approaching what would be the best goal for the families and for the patients, that is trying to reduce and even totally suppress the arrhythmic episodes. So the rationale of gene therapy for CPVT is really based on the fact that none of the currently used therapy is 100% efficacious in preventing the arrhythmias. Each therapy has its own side effects, and compliance, we know, is a critical problem. When we see this data from Hayashi was published this study in 2009, they reported a 32% of recurrency related to lack of compliance of patients. So to go beyond the issue of the risk of non-compliance to a lifelong therapy with tablets, we need to change the scenario. So I'm presenting here some of the data that we collected of our initial therapy that was developed between 2010 and 2012. At the beginning, we targeted the recessive form of CPVT that is caused by a defective gene that encodes calsequestrin. So the final results of the mutation in the recessive forms is to reduce the amount of the cardiac calsequestrin. We know that calsequestrin is a calcium buffering molecule, but we also know that calsequestrin is a protein that also works to stabilize in the closing state the ryanodine receptor. And this will be very important as we go on in this discussion on what is a gene therapy for CPVT and how does it work. So keep in mind that calsequestrin as a dual function is not just a buffer that binds calcium molecules, but is also something that tends to maintain the closing state of the ryanodine receptor during diastole. So if we want to reason on gene therapy and how the strategy is developed, I think we have a quite simple scheme. The scheme is that if we have a loss of function mutation, a mutation that reduces the amount of the protein, in this case of calsequestrin, or a mutation that reduces the effectiveness of the protein in performing its function, we want to increase the amount of this protein. So what we will do is to choose an overexpression or an enhanced expression of the protein. And how we do that is using a partner that is a virus modified to have two important features. Feature number one is that this adeno-associated virus should not be able to replicate in the cells, otherwise will be damaging the cells. And second, should be a virus that is as a tropism, so a predisposition to infect, in our case, cardiac cells. Of course, nowadays there are adeno-associated viruses that are tropic for heart, other for lungs, other for liver. And so the system has been able to develop adeno-associated viruses to perform effective and selective gene therapy to specific organs. For the heart, seems to be the serotype 8, 9, and 6 are the one that might be more promising. So basically, what can we do to develop a gene therapy? We take an adeno-associated virus, let's say serotype 9, that goes to the heart, and we put inside this virus that has been deprived of the DNA of the virus itself, the DNA, in this case, of the calsequestrin protein. Then the virus is injected in the blood. It goes to the nucleus of the cardiac cells, because we have said that it tends to go and to enter into cardiac cells because of how the capsid is organized and structured, and then injects in the nucleus the DNA of the protein that we want to replicate. Of course, the virus would normally inject his own DNA to replicate the virus, but the fact that we have deprived from his DNA turns the virus into a biological syringe, and effectors that will go in the nucleus and put exactly what we need, a DNA molecule that will compensate the lack of calsequestrin. So here is how a construct is built. So we have here the sequence of the wild-type calsequestrin, and in this experimental model, this will not be present when the study goes to human, a GFP protein is added so that the infected cells are fluorescent, and then we can study them and see how they have changed the clinical manifestation. Then we studied the effect of this gene therapy in newborn animals that were infected at birth. And then we studied them at 6, 9, and 12 months. And also in adult mice that were defective of calsequestrin. And once again, we studied them with a follow-up after viral delivery. So the results were quite gratifying. So what we show is that both in a calsequestrin knockout, so zero calsequestrin, we went from having the typical bidirectional VT that is present in this model to, after infection, having no arrhythmias. And as we see here, the arrhythmia reduction was very strong, almost brought the arrhythmic events to zero, very close to zero. And as you see, after 1 year, the efficacy of this single shot of the therapy was still present. Then when we have other mutations, so not the total deprivation, but just the reduction of the calsequestrin, of course, it's even easier to see an effect. We go from the bidirectional VT to no arrhythmias. And as we see here, after 1 year, the animals are still, the infected animals are still without any therapy. So gene therapy for recessive CPVT holds the promise that we might have, with one infection, the ability to normalize the phenotype of the patients and prevent the arrhythmias. This is interesting, but we know that the real challenge in CPVT is the dominant form. So we thought that maybe we could use the same therapy for treating also the dominant form of the disease. And this is because, this is the most common one. It would be a better impact on the fight against the mortality for CPVT, the fact that we can treat the dominant form. So as I said at the beginning, calsequestrin might work in the ryanodine receptor form, in the dominant form of CPVT, because we know that calsequestrin can stabilize the ryanodine receptor in the closing state during diastole. So it would prevent the mechanism that leads to arrhythmias, that is the leakage of calcium in the diastolic phase. That calcium is then exchanged for sodium and generates an inward current that depolarizes and generates the arrhythmic episodes and the arrhythmic events. So we started this challenge by now thinking of expressing in the dominant form of CPVT, so in a mutant with mutation in the ryanodine receptor, with our calsequestrin therapy. And so same adeno-associated virus, same DNA of wild-type calsequestrin. So what we tried to test different doses to see a dose response in the arrhythmic efficacy, and we tested low dose, mid dose, and high dose. And as you see, irrespective of the dose, we had no arrhythmias with the low dose, no arrhythmias with the high dose, and one animal that failed with the mid dose. But if we look here at the level of virus that has entered in the bloodstream of this animal is 0. So actually, this is not a failure of the therapy, but was just a failure that the injection was done in an improper way and never reached the bloodstream, was injected outside the vein. So it's very important that we have these results of 0 arrhythmias at a very low dose, 3 multiplied 10 to the 13. Just to give you a scheme, in gene therapy, it is now understood that going to a level that is 10 to the 14 is really too high. So to develop a therapy that is safer for human being, we need to stay in ranges between 3 and 5. Multiplied by 10 to the 13 per kilo of body weight. So actually, now we have demonstrated that calsequestrin in dominant form is so powerful that we could also use half of this low dose and have the same abolition of the arrhythmic events. And if we want to wonder how much is the increase of the protein, when we use the low dose, we have an increase by, as an average, by 3 times of the levels of calsequestrin. We know that toxicity of overexpression of calsequestrin starts with values around 10 times higher, 15 times higher, where Nolman demonstrated that a dilation of the ventricle as a consequence of an initial hypertrophy that then degenerates in dilatation and heart failure can be caused. So we think that we are on a safe dosage with our therapy, and that we can really think that the therapy with overexpression of calsequestrin can be an effective treatment for both the recessive and the dominant form of CPVT. And so we have just one therapy that at the same dosages can be used for the 2 conditions. Now let's move to long QT syndrome, where we have a very similar situation. The first approach in terms of therapy is beta blockers. We know that mainly non-selective beta blockers. That should be the first line of treatment in patients, and everyone is started with this therapy. We know that in long QT syndrome type 3, mexiletine is a gene-specific therapy, so a therapy that is specific only for the type 3, because mexiletine is able to counteract the excess of the late sodium current that is typical of this form. Then again, we have left cardiac sympathetic denervation and ICD implantation as alternative or integration to the beta blockers to prevent arrhythmias in patients who are resistant to the administration of beta blockers alone. And I would like to talk to you now about the gene therapy of one specific form of long QT syndrome, that is Timothy syndrome. And I want to talk about this because we have made a strong effort to try to identify a therapy, because these patients really have no therapy to which they respond. In fact, it has been reported that the average age of death in long QT syndrome type 8 is around 2.5 years. So it's a typical pediatric disease associated with marked prolongation of the QT interval. We see here that the QT is so prolonged that the P wave happens before the T wave. So it's very dramatic. Very often these patients exceed the 650 of corrected QT, and obviously a very high arrhythmic burden. So these are patients that really need a different therapy because they do not respond to beta blockers. They are very young, so the implant of a device is difficult, and the response to the innervation is also incomplete. So the genetic mutation is in the calcium channel and is a mutation that creates a defect in the inactivation. So the channel doesn't close as it should, and this prolongs the QT interval. So it's an excess of entry of calcium through the L-type calcium channel, while in CPVT, as we know, is an excess of the calcium released by the ryanodine receptor. So we decided to study a gene therapy, not in a model of mice, but to develop a swine model of Timothy syndrome. This because we think that in the mice, we have a very small heart, but if we would be able to test in a model, genetically modified model, a knock-in swine, we could really get data that are much more translatable to the human being. So this was a part of a ERC grant that gave a large funding to develop this ambitious project. So this is our first piglets that was developed in our facility in Italy. But then the study of characterization were performed in the laboratories that I have at CINIC in Spain, where we have also facility for doing electrophysiology in large swine when they develop. So look at here, just briefly, there is a high mortality in our Timothy syndrome pigs, similar to the one seen in patients, as you can see from this Kaplan-Meier curve. The QT is similarly very prolonged, like in humans. And we have documented by implanting these piglets with loop recorders that when they have death and they are found dead in their cage, they have had an arrhythmia as documented by the loop recorder. So the model is really very, very similar to the human beings. We have therefore been interested in characterizing isolated cardiac myocytes to confirm that the defect is located in the inactivation of the channel of the calcium current. So here we see that the wild-type calcium current, after a little bit, inactivates and is reduced as compared to the amplitude at the beginning. In Timothy syndrome, however, as it's been shown in mice, the current does not inactivate. It maintains the same amplitude and therefore prolongs the QT interval. So we confirmed in the cells of our mice, in the cardiomyocytes, that the defect is exactly the same that has been identified also in the mice model. So here we have a gain of function. We have a current that is too active because it does not inactivate. So we decided to use, in this case, another approach that is turning down the amount of the mutant channel. How you do that? You can develop, follow a strategy that is present biologically in the cells that is called RNA interference. There are small molecules of RNA that you can design that will bind to a specific mRNA and destroy it. So here we wanted to reduce the amount of the mRNA, messenger RNA, that will produce the mutated ion channel. And therefore, we tested this in a cellular system where we had the mutation present and when we had the wild type to document that this RNA molecule that we wanted to develop and test, that we could identify one molecule that would be selective for silencing the mutant allele, preserving the normal wild type allele. This is a molecule that really does not reduce much the wild type, but reduces much the amount of the mutant protein. And we tested this in the pigs. We see that the green cells are the cells that have been infected. When we study with patch clamp these cells, we see that gray cells do not inactivate because they still have the disease. But green cells, the more the green, the more is the recovery of the inactivation. You see that here it gets smaller, it rapidly inactivates. And when the cells are green, doing this, we would expect that they would also contribute to shortening the QT interval. And in fact, for example, this peak had a QTC of 580, and after therapy, it turned to 457. While, as we can see here, no changes in the QT of the animal that were not treated at baseline. So this is the baseline trace with this very long 559 QTC. And after 1 month, nothing really happened, just a small variation, but a QT that exceeds the 500. So this is not a chance event, but is really something related to the gene therapy that we delivered. So we were very curious to see whether, besides shortening the QT, this therapy was also able to modify the arrhythmogenic substrate. So this is the substrate of the local activation time, so the propagation of the impulse in a normal pig, not a genetically modified one. During the programmed electrical stimulation and during the S4, we have this normal activation. But when we have the mutant animal, we see that when we introduce an S4 in a programmed electrical stimulation protocol, we see the crowding of the isochron that are very massively present, and that we think create the predisposition of the substrate to develop reentrant circuits. Probably the calcium overload triggered PVCs, and then the PVC induced reentry because of this inability of the propagation of the impulse to be normal. So in these animals, then we injected our gene therapy. And what we were observed to see is that the entire right ventricle, left ventricle, and these are traces from the epicardial mapping, return in the range of the normal animal. So we are very pleased about this. Of course, it will take time to take such a therapy to the clinics. We will have to do more experiments. We have done so far 5 pigs that have responded well. But I think that really the promise that the gene therapy is taking is very different from what we can hope to get from our pharmacological approach. So I want to conclude by hoping that this overview on how much the genetics matched with cardiology and electrophysiology has really changed in the past 60 years the perspective and the hopes for the cure of patients with inherited arrhythmias. The field seems now to be ready or approaching readiness for full clinical translation of molecular therapies. And this will be a revolution for our electrophysiology practice, but most of all will be something really revolutionary for our patients. And with this, I want to thank you for your attention, and I'm glad to take questions.
Thank you so much, Silvia. It was an excellent, challenging presentation and showing us what's going on and what's the future going to be. That was very exciting. It's a long time I don't listen to this presentation from you, and I see the progress of the investigation you are doing. Really, it looks very nice and it promises a lot of things. As we are going to have a panel questions now, I'm going to take part of the English-speaking group, like Tom, and after Eugene, to make a short question for short answer from Silvia, so we can have many questions for her from the clinical aspect that we also want to know her opinion. Dear, well, whoever of you want to take the question, please, Tom or Eugene.
I'll go first. Silvia, grazie mille, ottima presentazione. It was a great presentation. I learned so much from you every time I hear you, and it's exciting to see where we're going, because we're going from putting a finger in the dike and preventing progression in the clinical manifestations to ultimately a cure. So my question to you is, as we go forward, especially with young children with these disorders, but even in adults, what are the concerns you have about the genetic therapy in terms of what it could do in other cells, either A, within the myocardium, or B, within the rest of the body? What are the things we, in your opinion, based on your background and experience, we need to watch most carefully for?
Excellent question. As a matter of fact, I think that the fact of making the infection selective to the heart is something that is pretty much addressed, because I have mentioned the capsid that already makes azeotropies for going to the heart, but we are also using the promoter. The promoter is what makes the expression of the therapeutic construct, and we can have a cardio-specific promoter as well that would not be effective in other cells. So that is not the major concern for toxicity of side effects, not to infect other sites, because we have tools to make it directed to cardiac cells. The real problem, the real issue, is the immune response. And this, for us cardiologists, is something that, it's a problem because we are not used to deal with immune reactions. But when I pointed out that the dose at 10 to the 14 is really a risky one, is because we know now, because I'm fortunate that several evidence from clinical trials, that when you exceed that level, when you go beyond 1 multiply 10 to the 14, really there is a very high risk of an immune response. And even pre-treatment of the patients with immune depressive therapies may not be sufficient. And it's also unclear because some patients have a native immunity, so they respond by producing antibodies, but other patients seems to have a complement-induced response. If you look at the New England of this week, there is an article, not on cardiac gene therapy, but on a gene therapy to skeletal muscle for Duchenne, where exactly giving a therapy at high dose, 10 to the 14, a guy with a patient, 27 years old, with Duchenne muscular dystrophy, died for any complement-mediated immune response related to the adeno-associated virus. So I think that the therapy that we have developed, both of them, we are lucky enough that they are working with dosages that are very low of the adeno-associated virus, at least in a preclinical setting. So we hope that this would be something that we can take to the clinic at this level, that is using 1 log unit lower instead of 1 multiply 10 to the 14, 1 multiply 10 to the 13. But still, if there is a challenge, is an immunological challenge. And this is something that is still the obstacle that is in front of us. And it's not only for the heart, it's in all gene therapies that use the adeno-associated virus.
A question, Eugene, please.
Silvia, thanks. Fascinating talk, obviously. So what would be that, to be successful in such innovative therapy, you clearly have to define what is the population you're going after and what is your endpoint. It's sometimes too dangerous to enter a game too late in the disease, and sometimes it's dangerous to enter it too early. So can you give us a glimpse of your thoughts? Like, where are you going? Like, what would be a patient you would love to be enrolled?
Yes. So I think that we need to keep separated the channelopathies and the cardiomyopathies. The channelopathies have the advantage that the disease is not showing an age-dependent change in phenotype. So it's not that we need to treat the patients in the teens for sure, because otherwise then it reduces the malignancy, and or vice versa. No, it's not that it's more malignant later than sooner. So in principle, I think that the trials will be done in patients, initially in patients above 18, because this is how FDA usually proceeds, or has proceeded for other treatment, for example, of hemophilia and these conditions. So they never start from the infants or the young children, from 18 above. And I think that adolescence or young adult is a good age to start. And what I expect, of course, we would like that this therapy can abolish the arrhythmias and have a long-lasting duration, so that maybe you need an injection at one point, it's the first injection, and then you need a boost 5 or 6 years later. This is the expectation, and is what we derive from other conditions and other diseases that are much more advanced than treatment to the heart. For the cardiomyopathies, I am more in doubt of what we could achieve, because clearly when you have a fibrotic heart, I don't think that we can expect that the fibrosis that exists at the time you give the therapy will decrease because you have given the therapy. The therapy can prevent the further accumulation. So in the cardiomyopathies, probably the point that you are raising, the need of having an early intervention is more relevant. On the other side, we have the doubt that sometime in a family, the mutation is the same, but one child will not develop the disease. So we also don't want to give the therapy to a child before we know that the disease is getting there. So it will be between maybe infancy and early adolescence, just to get the hint that that is a patient that is starting getting fibrosis, the moment for intervene and be active. That is what I can tell.
Thank you so much. Silvia, we are going to move you into Spanish. I am going to start speaking Spanish. So we are going to ask the Spanish-speaking people to make your questions, please. Move to the English version, please.
So I need to go with my in the Spanish.
Globe,
Can you hear me, Silvia? I'm Gabriel. I'm your interpreter. Can you hear me in English?
Yes, I can hear you in
Testing.
English.
Good, fantastic. So we'll
so
take
I
the
stay
questions.
as I am?
Yes, you stay just right there. Don't worry.
Okay, good. Thanks.
Dear friends, we have all our guests here. In Spanish, we have Dr. Floreal Cueto, Dr. Alejandro Bravo, Juan Cruz López Diez. We also have Analia Paulucci, who is the engine of the group for management of hereditary arrhythmias in our society, and I do not want to forget any of the other panelists. Alejandro, you have a question ready for Silvia, right? Yes. I have 2 questions. I'll start with one. Congratulations first for your presentation. Excellent. Is there some genotype that contraindicates the sports activity in an absolute manner in hypertrophic cardiomyopathy? Did you understand the question?
Yes, I did. Thank you very much for your question. In hypertrophic cardiomyopathy, we don't have a specific gene that makes the heart more susceptible to development, worsening of the cardiomyopathy or development of arrhythmias. It's different than the RVC, where we know that the desmosomal abnormalities are really something that the presence of a sport activity can worsen rapidly and generate a more severe form of the disease. So I think that the situation in the hypertrophic cardiomyopathy is that, of course, depending on the complication of the severity of the disease, whether there is a gradient, there is no gradient, one can decide whether the performance of exercise, intense and especially competitive, is contraindicated. But per se, a relationship between a specific gene subgroup and sports is not known.
So we will give Juan Lopez the floor. Juan Cruz, could you ask your question, and then we can give you the chance to ask another question later. Good evening. Thank you very much, Dr. Priori, for your brilliant presentation. My question is related to whether these modifications, genetic modifications, are able to modify the substrate of different arrhythmias. Are there in all diseases permanent modifications, or are there just transient or temporary? And what resources do you foresee in time regarding these changes, and how do they behave throughout time?
Thank you very much for your question. We need to consider that in nowadays there has been only one trial attempted for gene therapy to the heart, and this has been a trial that was designed for the use of the Cerca pump replacement in patients with heart failure, and the trial was negative, meaning that it didn't work. And oops, sorry, I have lost my. Can you hear me or not?
Yes.
Okay, sorry, I have lost the here. Okay, now it should be better. So I was saying that in the I have lost the track. The question
Was about if this substrate modification was permanent or
okay.
it was transitory, and
yeah.
if
So in
every single pathology. So.
Right. I was saying that we have only one trial, and the trial was negative. And probably in that trial, the conclusion of the investigator was that the dose was too low. So basically, we are starting from ground zero. We have no precedent trial or experience to say this will resist for many years, will be something very transient, or will be something that require a boost after 6 months, 6 years, or what. So definitely the first studies will be the one that clarify and provide this answer. It is known that the transgene, so the molecule that is the therapeutic one, that can be the DNA or the RNA molecule, can be tracked in tissues 7-8 years late after the gene therapy in other diseases. So not when the heart is the target. So we have reasons to suppose that if the transgene will reach the heart, it may stay there 6-7 years. But until we have a demonstration of the first clinical trial, it's definitely difficult to make any educated guess about that.
Okay, perfect. Thank you very much.
Alejandro Ventura, una pregunta.
Alejandro Ventura, you have a question? Good afternoon. I would like to congratulate Dr. Priori for your excellent presentation. It is a privilege to be able to hear a conference where we can see the future of medicine. It seems a little bit like science fiction for some of us. I'd like to ask you if you have experience in gene therapy in Brugada syndrome, and what do you think about a patient like a case I've seen in the interior of my province who has a Brugada syndrome type 1 by EKG with sudden death, and also in the MRI also has RV, arrhythmogenic dysplasia as well. What do you think of this association, please?
Yes, it's a very interesting question. I can quote the studies of Marina Cerrone and Mario Del Mar, who have described the fact that there is an interplay between the loss of sodium current and the presence also of abnormality at the desmosomal level. So some overlapping between the Brugada syndrome and the RVC can be anticipated based on their study and this evidence that they have reported. Of course, the evidence comes from mice models of the disease, but it's something where there is more and more thinking of how this could be mediated and whether we could develop a specific therapy for counteracting this coexistence of the two phenotypes.
Perfecto.
Thank you. Alejandro Bravo, a question? Can you hear me? Hello, and thank you very much for the invitation to SADC, and thank you, Dr. Priori, for your clear presentation. I would like to ask about the molecular autopsy. These young patients with sudden death and normal cardiac workup could have a channelopathy, but to do molecular autopsy in these patients in order to see how in the family, if there's some penetrance in the family or not, and what would be the conditions or the indications currently to perform such molecular autopsy? Thank you.
Thank you very much for this question that is very important and the issue is very debated. Unfortunately, in very few countries, there is a systematic regulation of when an autopsy is required, and more importantly, in very few countries, there is then the action taken of requesting an autopsy from either the medical side or the legal side. So unfortunately, it is not done, while obviously for the reason that you mentioned, that is the importance of defining a therapy, defining the mutation for searching the mutation among the family member and prevent other sudden death. It would make sense that every case of unexplained sudden death receives among the investigations an autopsy. There are protocols in the UK, there are protocols in Australia, but in most of Europe, there is not a systematic approach. So my perspective is that it should always be performed, because even if it's clearly something devastating for the family that has such a terrible loss, also to see that the body of a young person gets open, cut, and studied for defining whether which was the cause of the death, it may save life of other young people. So I think that we should also educate the population about that.
Gracias. Analia Paulucci, ¿tenés una
Analia
pregunta?
Paulucci, you have a question? Good afternoon, and thank you for such a passionate issue and talk. My first question has to do with how you perform the assessment of the arrhythmic burden in mice, mainly, where you are performing the studies with a long QT. How do you do the assessment of the response to transgenic therapy? In the case of Brugada syndrome, which is my second question, in fact, where maybe the arrhythmic burden is less, we know that they have a little bit less ICD triggers. Would that be the decrease in the pattern with regards to the amount of arrhythmias in Brugada syndrome?
Thank you very much for the question. First of all, in the animal model, how we monitor the arrhythmias depends on which animal model we have. In the mice, we implant a telemeter that is like a Holter recording on the back of the animal, so that the other animals will not bite it and try to remove it, or the animal itself. And so we can monitor for weeks all the arrhythmic burden in the animal. So in the case of CPVT, this is done when the animal is injected. Before the injection, we implant the telemeter, we check the resting phase, what happens before the therapy and what happens after the therapy. Then we can also do an acute provocative test per inducing with epinephrine the arrhythmias, and to see whether the arrhythmias were inducible before and not after the gene therapy. I decided to move to pigs because, as I have shown, is much more solid to perform the mapping of the heart, and seeing that there is a substrate that usually in long QT syndrome, for example, is dispersion of repolarization and slowing of conduction and reentrant arrhythmias, and evidence also of PVCs that may originate from different areas and are reflection of early after depolarization in general in the long QT. And then by mapping, I am much more convinced that it's not just a chance that I am not recording arrhythmias when I do either programmed electrical stimulation or I do a long-term monitor with a loop recorder. So this is why we are shifting now, and I mean it's very expensive, but it is worth, because at the end we are not studying 25 diseases, but there are 3 or 4 that are important. Unfortunately for Brugada, I cannot tell you anything because I have done a pig with Brugada syndrome mutation when I was in New York with Dr. Fishman. And unfortunately, the animal model, after having a truncating mutation that reduced the current by 50%, never developed the pattern. So we don't know why the pattern was not there, but the phenotype of the animal who had the same mutation of human beings with the ST segment elevation was instead AV blocks. And so was a different phenotype. So I don't know how to tell you, because really the animal was never a good model for the disease. And I don't think that we have a very good mice model as well.
Perfecto, muchas gracias.
Alejandro Cueto, la última cortita.
Alejandro Cueto, the last question, very short, so we can let Silvia rest. In case that you could be able to achieve the gene therapy, do you think that you could go back to, in the case of athletes, could they go back to maybe full activity, and how long would that take? How much later?
Yeah, I think that yes, the hope that we have for the gene therapy is that can give an interval without arrhythmias that, as I said, I cannot tell you whether I think it's going to be 3 years or 6 years or 8 years. But if the athletes is kept under reasonable monitoring, just to be sure that there are not breakout in the efficacy of the therapy, if they really do not have arrhythmias for maybe 6 months, or when they do an exercise stress test, after careful challenging, I think that they could go back to the activity. But, we need, of course, to see the first experiment, the first clinical trials, which results they will give on the duration of the therapy, because the therapy may have an effect that is equal in all the patients, or can be just that the patients respond and then inactivates the transgene for some reasons, and other patients do not inactivate the transgene. So we will have to see.
Silvia, querida.
Thank you. Dear Silvia, I only have now to thank you deeply on behalf of all our groups, the World Society, the Argentinian Society, that we really are so pleased to learn everything you teach us with your passion, and we admire you so much, what you have always given us in the investigation of these arrhythmias. The Argentine Society of Cardiac Stimulation has named you an honorary member of your society, and we will send you the diplomas, but you always convey in all your presentations the depth and your careful investigation, how human this research is. And sorry for having you work so late in the night. We admire you so much for the good of our patients and for the good of us learning so much from you. Thank you very much.
Thank you very much for the invitation. Thank you very much for the award you are giving and sending to me. And thank you very much for all the people in the audience and the very interesting question that they have made. Have a good evening.
Adiós.
Bye.
Goodbye.
Bye-bye.